Righty. All right, thank you. First, let me allow the physicians to introduce themselves. All right. I don't know what order you are as far as your screen is concerned, so I'm going to call each physician's name. Dr. Atherley, please introduce yourself.
Good afternoon, everyone. My name is Trevor Atherley. I'm an interventional cardiologist. That means that I take care of all aspects of the heart, but my special interest is in invading the heart with tubes and for diagnostic and treatment purposes. So I'm an interventional cardiologist. I'm primarily based at Newark Bethesda Medical Center, and a lot of my time is spent in teaching the younger cardiologists. Good to be here.
All righty. Dr. Lee, James Lee, Jr.
Hi, Dr. James. I'm a surgeon, board certified, specializing in sports medicine and general orthopedics. I take care of the musculoskeletal system ranging from the extremities, shoulders, hips, knees. Practice is based in West Orange. I also do some teaching as assistant professor at Rutgers University.
All right, thank you. Dr. Nelson Aluya.
Well, thank you for having me. It's a pleasure once again to be here. My name is Nelson Aluya. I'm a medicine and pediatrics trained assistant professor at the New Jersey Medical School in Rutgers, New Jersey. I'm also a primary care attending at the Newark Bethesda Medical Center, Newark here in New Jersey. I call myself a medical advocate, and I'm here to contribute to the healthcare of everyone. Thank you.
All right. Dr. Douglas Taylor. Dr. Taylor?
Can you hear me?
You're on mute?
No.
Are you? Turn your volume up.
Can you hear me?
Very,
very. We need the volume up.
I am in trouble. Is it better?
No, it's not better. You're very low as far as volume is concerned. All right, Dr. Taylor, I'm going to let you work on that, and we're going to go to Dr. Kendall Sprott, and we'll come back to you.
I am Kendall Sprott. I'm board certified pediatrician, former chair of pediatrics at New Jersey Medical School. And my background is in general pediatrics and pediatric critical care.
All righty. And Dr. James Court. Dr. Court.
Good afternoon. My name is Dr. Court. My specialty is internal medicine. I treat adults. I don't do surgery, neither do I do little babies. I graduated from Howard University many, many years ago. Thank you.
All right. Dr. Kevin Clark.
Good afternoon and welcome. Dr. Kevin Clark. I'm a surgical oncologist. I treat cancers of the skin, soft tissue, breast, and the GI tract. Looking forward to hearing from you guys.
All righty. Dr. Patrick Anderson.
Good afternoon, everyone. Honored to be here with this group of illustrious physicians. Hope we can answer many of your questions. I'm a board certified gynecologic oncologist, director of the Division of Gynecologic Oncology at Newark Bethesda Medical Center. Primarily, we treat complex gynecologic issues and treat women with gynecologic cancers. Good to
and
be
Dr. I'm sorry, Patrick, finish.
No, I said good to be here.
All righty. Dr. Jordan Garrison.
Hi, my name is Jordan Garrison. I'm a board certified general vascular and bariatric surgery. After spending 20 years as director of bariatric surgery at Christ Hospital in Jersey City, I've now transitioned into a practice dedicated to venous surgery. We have offices in Hackensack as well as Florham Park. I'm appreciative of the opportunity to share some of this knowledge with you folks. Thank you.
All righty. And Dr. Douglas Taylor.
Am I any better?
All righty. We're still very low, Dr. Taylor.
I did everything that I know, but it's so, I don't want to switch off and come in again.
Yeah.
I will shout.
And maybe get closer to the computer. That may help.
Bring the mic. It's built-in mic. That's a problem. I'm an infectious disease specialist based mostly in East Orange, but I do consultation in East Orange, the South East Orange General Hospital, Bethesda.
It's better now.
Better.
And also St. Barnabas. I hope by the end of the day I would have answered the questions that are put to me, and those answers may be helpful.
All righty. Thank you. Thank you. Your mic is much better now. Your volume is much better.
Okay, thank you.
All righty. I'm Dr. Omar Bey. I'm a pulmonary critical care physician, specialty in nutrition. And I'm just so glad to be here, boy, with this talent here. We have so many years of medicine right here on the screen. Let me just set some ground rules. We're trying to have no big words. We're going to break it down. We're going to have our physicians try to remember that. We're going to break it down so everyone can understand what we say. Also, what I'd like to say is that do not change any. I really mean this. Do not change any aspect of your medical care until you consult your physicians. Very important. We're all different. One medication that may be fine for me may have you may have an allergic reaction to. So please do not change any aspect of your medical care until you consult your physicians, no matter what we say. Also, I'd like to thank OBHealthy for allowing us to use their platform, OBHealthy Weight Loss Network. Thank you very much. We'll have to just bow because I'm not worthy. You're letting us use your platform. All right, let's get going as far as questions is concerned. We have a few questions coming in already, and let's start off with one for Dr. Atherley. This question says, what happens to the heart when you have a heart attack? And that question came through. Dr. Atherley, can you help us out?
Sure, I'll try. Well, let me just discuss a bit about the heart and then tell you what specifically is a heart attack. In general terms, a heart attack refers to damage to the heart muscle. The heart is, in fact, the most powerful muscle you have. You know that although it's about the size of a fist, if you want to get an idea of its size, it is very powerful, and it does pump about 2,000 gallons of blood per day, continuously acting. In order to function properly, the heart not only pushes blood to other parts of the body, but it itself has its own select supply of blood. And this is met not by the blood that is coursing within the chambers of the heart, but instead by small separate blood vessels, small arteries, which run on the surface of the heart. One of the most significant diseases that we have, and one of the major causes of mortality, death in this country and worldwide, is heart attacks. Heart attacks most commonly occur when blockages, a blockage or more blockages occur in the arteries of the heart. This can occur in a variety of means, but let's go by the most common. Essentially, the heart arteries become blocked gradually over a prolonged period of time by deposition of fat. Fatty materials are deposited into the walls of the arteries, gradually narrowing those arteries. There are certain stimuli, certain things that may precipitate sudden total closure of the artery. So you may have an artery, normally this wide, and gradually closing over the years, and eventually, because of some specific stimulus, sometimes stress, other factors that we can discuss in the future, it suddenly closes off. Then what happens is that the area of the heart muscle, which is normally supplied with blood by that specific artery, no longer has any blood. And the powerful muscle cannot function in the absence of blood. So it starts to, over a period of hours, to die. And death of that heart muscle in that manner is called a heart attack. Now, it is important for you to recognize when a heart attack is occurring, because we don't just sit back and allow it to happen. Nowadays, there are many things we can do to intervene. This is what an interventional cardiologist can do. We intervene to slow down the process of death of the heart muscle. It's not instantaneous. It gradually dies over a period of hours. Some people feel up to 6 hours, so that we can intervene and restore blood supply to that part of the heart muscle, and so save damage to the heart. Because a lot of the complications, a lot of the subsequent events that occur to the heart, acute or later, occur as a consequence of the amount of muscle that is damaged with the heart attack. So we try to minimize the heart attack. So death, full death of the heart muscle is irreversible, and we cannot regrow that muscle once it has become permanently damaged. So it's our onus, or we have indeed that obligation to try to minimize by quick treatment when patients present with heart attacks.
Yeah, thank you, Dr. We have some feedback. Do we have, just check that, please make sure we don't have some feedback here. there are a lot of questions coming in, and there's another question for Dr. Atherley, but I'm going to go to the second question and then come back. I am in my 40s and have a family history of dementia on both sides. Are there any precautions I can take now to help prevent this in the future? Any of the internal medicine doctors, Dr. Cord or Dr. Aluya, and can you help us out with this?
One aspect of dementia related to aging, also another aspect is related to multiple episodes of strokes as a result of high blood pressure or plaques that break off and embolize to the brain. So one of the things that we can do, especially to prevent multi-infarct dementia, is to control the blood pressure and control other mechanisms or things that can cause clots to develop later on. The other aspect of dementia is generally related to your genetics. If mommy or daddy has it, it's very likely that the children may develop it. One of the things that supposedly help prevent that type of dementia is what's in vogue right now, use of vitamin D. Anecdotally, we were told that vitamin D helps to prevent dementia in some way or other. The mechanism of action, we don't know yet. So one, if you control your blood pressure, you're likely not to get multi-infarct dementia. If you control the causes of plaque formation, that can also help to prevent these multiple strokes, which can lead to dementia, if enough of the brain is damaged.
All right. Anybody want to add to that?
Well, if I may add to that, just like Dr. Quartz rightly said, uncontrolled, sustained, blood pressure that's not controlled for a very long time, increase your risk of having minute, tiny strokes over a large area of the brain over time, that increase the risk for strokes, for dementia. That's problem with memory. There are different kinds of dementia. They have vascular, you have Alzheimer's dementia, and all the other types of dementia. But then there are some that also come from infection as well. Probably infection, viral infection usually, that you may have even as a child. Measles and all those, common viral infections that can happen, that over 20, 30 years down the road can begin to give you, risk for memory issues. And of course, you have problems with genetics. If you've had, strong family history of dementia, where you begin to have deposits of plaques within the brain. Now, we have issues of trauma to the brain, repeated trauma to the brain over time as well, or from an accident or from high impact sports, that over time can increase the risk of damage to those tiny cells in the brain that can begin to cause you problems with memory. So these are issues. Now, what he said was prevention. How do you prevent that? First, healthy lifestyle. Know your history. Know what your risk factors are. Know what your family history is. Your mom, your dad, even your grandma, grandpa, uncles, and aunts. Those are the things that we often forget in our community that impact our health over time. So if you know that, so that you begin to take steps to mitigate some of those issues. One, high blood pressure. Make sure you control your high blood pressure. Two, diet. If there's risk of diabetes, control diabetes. High cholesterol, you have to control that as well, because those impact every other aspect of the vessels all around you as well. But one significant thing that is really very important that has been shown to help with memory, one, exercise. You have to exercise, because what it does is actually help increase the size of the blood vessels and keep them firm, and I'll use the word malleable, meaning they can expand and contract well enough, and then push the blood flow through to give supply to the brain, as well as take away the byproducts that have been produced from over time. So exercise is and healthy habits and healthy life.
Excellent, 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 excellent. The next question, Dr. Atherley, you're popular today. This is a greetings. It says, could you please discuss what heart block stage 3 is?
Heart block, sorry?
Heart block stage 3.
Oh, okay. All right. Well, I mentioned earlier that the heart is a muscular pump. In order for the heart to function effectively and appropriately, it is stimulated by electrical currents. They usually start at the topmost part of the heart and go down gradually to the bottom parts of the heart. And they synchronize the heart activity so that the 4 chambers that together make up the heart chambers are functioning in synchrony, so that the most efficient way of pumping the blood to the lungs to be oxygenated, and then back from the lungs to the rest of the body to serve the purposes of providing oxygen and nutrients to the body. These all have to be properly synchronized. Now, the electricity can at times go awry. We have a variety of blocks, that is, where the electricity does not follow the full pathway from the top to the bottom in the normal manner. Sometimes it just goes a little more slowly, so the heart itself may be powered to function a little more slowly. Sometimes it takes a little longer, but every beat still happens to occur without any skipped or drop beats. That's called first-degree heart block. Second-degree heart block is where some of the impulses from the top make it down to the bottom, but others don't, so that there are some skipped beats. You're experiencing beats because of the powerful movement and contraction of the lower chambers. You not easily experience the upper chambers. So if the lower chambers are not powered to beat, you may experience a skipped beat. And third degree or complete heart block implies that the whole system has gone awry and that the impulses that are initiated from above never reach the bottom. And the bottom chambers have an intrinsic ability to function even without receiving any impulses from above. That usually is associated with a slower heart rate because those chambers, their natural rate of beating is much slower than the upper chambers. And so the upper chambers beat at one rate, the lower chambers at another rate, and the two do not communicate. That is third degree or complete heart block. Sometimes we require to restore the rhythm and the synchrony of the heartbeats, and that is where pacemakers may be required, an electrical device that can be implanted to stimulate the chambers to beat in concert.
All right, excellent, excellent, excellent. There's a, I'm going to come back to these questions because a lot of them are dealing with cardiology, so we're going to come back to you, Dr. Court, in a minute. But what I'd like to do is I'd like to get in some questions in that came in about COVID. Is COVID worse if you get it a second time? Dr. Taylor, can you start us off on this one? You get COVID, you get through it, and if you get it a second time, what's going to happen to you?
The doctors people have described recurrence, but this has never been proven. You get it, you recover, or unfortunately can die. But as far as recurrence, I know there have been cases where people have been retested after recovery and they have been tested positive. The clinical significance of that is not known. But again, there's no data that you can get reinfected and have a disease. There's no data. So I cannot comment much on that.
Okay. Another thing, is it true that you can get COVID more than one time? That there's articles that are coming out that they are finding people that possibly have gotten COVID once and then gotten it again.
The thing is that the tests we're using now, they are not absolutely perfect. So you cannot tease out whether a test done on somebody who initially tested positive actually had the disease or had the infection. That's my opinion. If it happens that the first test was false positive, yes, you can get infected again and get sick.
Right.
But again, it's a very fuzzy area. You don't have much on it. I know there are a lot of.
But I think Omar, if someone has a false positive, that
Right.
means that they never had it. So
Okay.
the test was positive, but they never had it. So if they had a false positive, they mean they never had it. And then they may think that they had it, they didn't. And then if they test positive again, that's the case. But I think that the real question is whether or not that's possible or not. And if you get COVID, the normal individual develops antibodies against it, but we don't know the level of antibodies that an individual might build to prevent it from happening. So, and we also don't know whether or not the antibody that is developed after exposure lasts a long time. You know, with a lot of infections, you have a viral infection, you have antibodies, and if it's high enough, it'll prevent you from getting it. But if you don't have a high enough level, you can be re-exposed and actually get it. And I think there are some cases that, and it's just a few, of individuals who have tested it positive. That means that they've tested to look for the viral particles in them. It goes away, and then they get retested, and it's positive again. We don't know. There's maybe some logic to the fact that it might actually be less harmful than it was before, because there is a level of antibodies that you might have that might reduce the kind of effects. But a lot of the harmful effects of the infection are related to inflammation that occurs and the damage that occurs with inflammation. And when we were talking about dementia, and I'll just specifically talk about Alzheimer's, there is an inflammatory component associated with Alzheimer's. And it may be that if one takes anti-inflammatories, like ibuprofen or naproxen or some of these other things, it might have a beneficial effect in either your development of Alzheimer's or the kind of morbidity that you might have associated with it. So it's important to sort of look at. And some of the literature suggests that that might be very beneficial to some individuals and not so much for others. So it's something that you need to think about, that if indeed you start to have some signs and symptoms of Alzheimer's, that trying to mitigate some of the inflammatory components that occur later on might be helpful.
All right. You know,
Can I ask experts on that same one, Omar? Because I'm particularly concerned about this reinfection. There's one well-publicized study of a patient from Hong Kong, for example, who had the infection first, and then later on went to Europe and got another episode. And there's a question of variants having the same. Does that occur? Is that a problem we should be worried about, variation in the actual virus, so that we can be affected by a second variant and have no protection against that one, having been affected by a different variant initially?
You talking about being sick or just testing positive?
Well, I think I think what and this is one of the issues that was spoken about before, is that, you know, we're talking about coronaviruses. It's not just Corona-19. Some of the tests may not just be specific for Corona-19. It may be include positivity for other viruses, or it may be a different Corona than 19. And so there's a lot of sort of lack of understanding about how specific they are about the specific coronavirus, or whether or not there's a mutation that might occur that might make you have a different kind of coronavirus 19 even. So, and again, this virus just popped up, you know, less than a year ago. And so that's why they call it a novel virus. We don't know a lot about it. We don't know a lot about the testing that's done. There are a lot of different tests that are out there. Some of them may be more specific than others, but there's so many tests, and I don't know that anyone has a real complete understanding as to when something is positive. Does it mean you're talking about a specific type of corona, or maybe a variant? We just don't know yet.
Omar.
Yeah.
From what I understand, the patient had another strain of the coronavirus. It wasn't the same as what he had before.
Right. So do you think it's mutating? Is that the possibility? Meaning that it's changing its form so that it attacks differently, or may show different symptoms, or, you know, where, you know, this is, the problem is that we still don't know enough about this virus.
Correct.
But Omar, let me speak a little bit about that.
Okay.
Most of the tests that are done for coronavirus aren't very specific. They're looking for particles of the virus. They're
Right.
not taking the virus and growing it to determine the various strains of it.
Right.
So, and again, they're different. Not everyone that gets tested for coronavirus gets the same kind of test. And
That's
so
right.
you
Yeah,
know,
they're different
so
tests.
we're not talking about growing, taking it and then sending it to the lab, growing it, and then looking for the specificity of the DNA of that. That almost never gets done. It is done specifically in research, but the majority of people that are being tested aren't being tested to look for that kind of specificity.
Right. So it could be different strains, but showing positive, but not the same strain in different people.
Right.
Now,
Well, if I may add something quickly.
understand that they're taking bits of the
Hold on,
DNA,
Dr. Douglas, and then Dr. Aluya. Go ahead, Dr. Douglas.
take bits of the genetic material and grow it. I mean, it's a recombinant test.
Mhm.
So even if there's a small particle that resembles the virus, right, it can eventually, when they do the amplification test, it can come back positive. Again, that's why you have to relate whatever you are doing to the patient's clinical condition. If the patient is not sick and you test, it's very difficult to interpret it.
Yeah.
Or somebody who's, like I said before, somebody who's supposed to have recovered, you get retested and it's positive. What does it mean? We don't know.
Yeah, we don't know. All right. Dr. Aluya.
Well, I mean, like I've always said, the coronavirus, this novel one, is writing its own textbook as it goes on. We're beginning to really know so much about it. And the first reports of secondary exposure and reinfection was actually, you know, in the early times of March and early April, came from Korea, actually, South Korea, and where some people who got infected before were shown to be reinfected. However, they didn't come down with the same severity of the disease that they did the first time. You know, there are a couple of reasons for this. Either because one, because of the reinfection, they did, you know, develop antibodies against it, which would help dampen the effect of the second, you know, reinfection. And of course, probably they know better now how to handle the disease on the second run as compared to the first run. But no doubt, like I've always said, unless this virus is from the depths of hell, it should behave like its cousins, which is the SARS and the MERS. So we know studies that came from all that did show that for MERS, antibodies will last for about 2 years, for SARS, about 3 years. As a matter of fact, the latest study, I think that came out last month, actually it did shed some few people, I think a few percentage, 15% do show for the last 15 years, they still have antibodies of the SARS-2. So, you know, it depends on what your immune system is like and what how much response you can do that can help you survive, you know, a secondary exposure.
All righty.
Omar, may I say
Dr.
something?
Lee.
Yes, and my limited understanding is that, you know, many of us are going to receive the flu vaccine this fall.
Right.
Isn't there a lag time with what strain of flu that is? You know, we're not getting vaccinated against the new evolving flu. It's the past flu. So, you know, there's a talk of vaccine for COVID, corona. Same idea. You know, are we truly going to get immune? Are we, you know, with the flu vaccine itself, are we getting true to the new flu virus? Or is it the old flu from, you know, 6-9 months? Also kind of plays into this conversation of the lag time of what we're researching into what is happening in real time.
Right. Well, that's true. That's true.
The flu vaccine is generated from the circulating virus at the end of the last season. Because if there's anything going to happen, it's that group that's going to cause a problem this year.
Right.
Yeah, so each year the flu vaccine is a new vaccine.
It's different.
And what happens is that the way flu sort of moves is from Asia down south and then across. And so each year they make a prediction, and sometimes they're right and sometimes they're wrong about which of the 3 influenza viruses are most likely to cause epidemics in the coming year.
Right.
And so the infectious disease folks from around the world get together and make a prediction as to what it is, and that's how they go about developing the vaccine. And sometimes you know, if the prediction from last year predicted a virus that didn't do so much damage, but they think that it's around and might cause damage, they'll re-include that vaccine, that strain in the vaccine. But in general, it's usually either 3 new types of influenza or 2 new types and a return of the old type, but it's a new. And again, if you get the vaccine and you're exposed to either of those 3 types of influenza, you have a good chance of either not getting it or having not so severe symptoms. But if you get exposed to a type of influenza that wasn't part of the vaccine, you can have influenza just like anyone else.
Right. Yeah. Well, what I'd like to do, go ahead, Dr. Nelson.
Yeah, so since we're talking about the flu vaccine, just like you rightly said, they look at the most common ones that, exposed the year before, 2 or 3 years before, and then come up with the vaccines that will cover most people. But 2 things that really does happen, and that's why sometimes they tend to miss it. And I don't want to sound too technical here, but there were words that antigenic shift and antigenic drift. So those are things I don't want to go too much into that, but those are things that affect the amount, the type of vaccines that are produced for the year. For the year 2019 and 2020, the CDC has recommended the flu mist, which is the quadrivalent flu vaccine for this year. So most likely that's what's going to come out this year. So if you see your doctor, when you go for your visit for this season, because like I always say, when is the best time for you to get your flu vaccine? Before the flu season starts. And that's in, early falls, around early October. And you can get it anytime within the flu season, which is the commonest will be between December and March. So, but remember, you can always still get the flu any time of the year. So, but the best time to actually get it before the flu season really starts.
All righty. Thank you. We're going to go on to another topic. We're going to come back to that in a minute, though, because I got a great question. Actually, since we're on that topic, let's finish it off, and then we can get to some other questions and bring some of the other doctors in. This is a question that came through. I don't trust how they are rushing this vaccine and talking about COVID-19 vaccine. Are we going to be guinea pigs for testing it? And obviously, I think this came from an African American. Is it effective? What are the side effects? I don't think I'm going to take it. What do you think, and what do you advise? Anyone have any thoughts on this? Because this is our community, and our community
unfortunately,
is very cautious with this thing.
Well, Omar, I can say that there were some people in Newark.
Hold on, Dr. Sprock. Dr. Taylor, start off and let's take one at a time, because I know a lot of people may want to comment on this. Go ahead, Dr. Taylor.
Unfortunately, there has been a very bad development in that medicine and science is being mixed with politics. And that's a no-no. I think that the folks at the various pharmaceutical companies, as well as the federal regulating agencies, will not release the vaccine without good data.
Mm-hmm.
So I will ask the person to rest assured, this is not politics, this is not guinea pig. When it is ready, all the information will be available to make him, as an individual, make a decision as whether he wants it or not.
Mm-hmm.
But unfortunately, the whole atmosphere today it makes people very, very, very suspicious of the vaccine.
Yeah. Okay.
Omar, if I may say something.
Dr. Taylor, put yourself in the middle of the screen, please. Dr. Sprock and then Dr. Anderson. Go ahead.
Yeah, I can say that just last week there were some people in Newark protesting because the medical school that many of us are associated with is involved in a clinical trial by one of the pharmaceutical companies that are looking to test both the efficacy, that means whether or not it's going to be effective, and two, the safety. There's always been an issue related to testing by pharmaceutical companies of African Americans, back from the Tuskegee incidents where they gave folks syphilis. And so there's always been a certain amount of reluctance to participate, although it does make sense for African Americans as well as Latinos, all parts of the spectrum, to be involved in certain types of clinical trials for whatever it is, hypertension, everything else, because it isn't until after something comes out that you see whether or not it's more effective or less effective in certain types of population. And we know that this virus has disproportionately affected people of color, especially African Americans, Latinos, and it may be not related to genetics. It could be related to social situations as well. Although I think that as Dr. Taylor talked about, there does seem to be a lot of politics involved in what's coming out in terms of pressure from the president on NIH and on CDC, and promises that are more focused with his possible reelection. I think, though, the people that are conducting the studies are mindful of the fact that again, if something isn't safe, and you heard of the halt of the clinical trial because of someone getting transverse myelitis or some damage to their spinal cord. So I think that people ought to be cautious about anything that comes up too quickly, because just like anything else, unless you have wide exposure, some of the side effects won't show up in an initial cohort or initial group of people that are tested. So you talk about 30,000 folks. Well, you're talking about 200 some, almost 300 million people in the United States. So you might not have something show up in 30,000. It might show up in 1 million or 3 million. And so the more folks that are involved in these trials, the better. But still, by the time it gets released, the largest number of people won't have gotten the vaccine. And so I think that people are, because of the politics, are going to be cautious about it. Although I think that the vast majority of the people in this country and in other places have not yet been exposed to the virus. We're talking about, when we look at some of the testing now, less than 1% are testing positive. Well, that means that 99% aren't testing positive, and they still may be at risk of getting infected if exposed. So I think that for me, people should remain cautious until a vaccine comes up that is proven to be, number one, effective, and number two, to be safe. Because you don't want to get a vaccine and then get complications related to it. So I would be reluctant, but I'm at the age where if I get it, I have higher incidence of getting sick. And so I'm looking for a vaccine, but I want to make sure that by the time I get it, it's safe and effective.
Safe and effective. Dr. Anderson, please.
I was just going to make a comment, but some of my comments will echo some of the things Dr. Spratt and Dr. Taylor mentioned. We need to understand that these vaccines, the trials are being conducted in a different time and setting other than when the Tuskegee experiment occurred. And we cannot enjoy the benefits of a product if we did not contribute to its development and then worry about being guinea pigs. The truth of the matter is, in today's scientific community, when you apply the purest sense of structure, there is a process. And if we all know, as being affiliated with the medical schools and universities, that there's usually an institutional review board that signs off or supposed to sign off on all these proposals. And there are systems where there are informed consents, and the participants are supposed to be counseled extensively as to some of the things that are known to have occurred or that can occur, including things that we don't yet know. And people who are participants are followed extensively over time. Now, we need to understand the scientific structure of the research, the phase 1, the phase 2, and the phase 3. Phase 1 looking for toxicity, phase 2 looking at for effectiveness, and phase 3 comparing different products to one another to put the best product out. So we can talk about being guinea pigs. I think we're using these terms loosely. I think if we want to enjoy the benefits, everyone wants to get back on a plane, and we won't do it until we have an effective vaccine. But how do we gonna know if it's effective? And then there's the other issue of differential response based on race and genetics, right? We know from all various studies looking at blood pressure medicine, not all blood pressure medicine work in African Americans. Well, if we don't participate in clinical trials, we won't know. So I think it's incumbent upon us, as in this platform, to educate our community as to the importance of participating, but to be educated enough to ask the appropriate questions and be relatively comfortable participating with the understanding that there can be side effects, there can be untoward outcomes.
Right, right. Definitely, definitely. We're going to go on to another question here. This is a question about cancer moving around the body. How and why does cancer move around the body? Dr. Clark, can you start us off with this one?
Sure. So I think the first thing is to kind of explain what cancer is. And it's a growth. It's an abnormal growth that can occur in any of the organs in the body. Usually the most common cancers that we see are breast, lung, and colon. In males, prostate cancer. Now, the problem is not just that it grows out of control, but that it can go to other parts of the body and cause spread. And when it does that, that's a condition called metastasis. That's actually the hallmark of a cancer, is its ability to not only grow in the organ that it's from, but for it to spread to other parts of the body and cause damage. Exactly how it does that, it's a little bit detailed, but in addition to acquiring the ability to multiply without control, it acquires what we call mutations that allows it to go into the bloodstream and then to go to different parts of the body and multiply. That process itself, fortunately, is not very efficient. So the majority of patients, it takes years and it takes a lot of mutations for a cancer to start at one site and potentially go to other sites. Now, the way how we kind of determine, I think there's another question in terms of stages. So we typically stage cancers by what we call the TNM classification. But simply put, it's either localized, it's regional, or it's spread to other parts of the body. So cancer is either in the organ itself of origin, so it's in the breast itself. If it's gone to what we call the regional areas, it's in the lymph nodes, so the surrounding lymph nodes of the tissue. And if it's metastasized or spread, it's gone to either the lungs, the liver, or the bone. So typically it's stage 1, 2, 3, and 4. Stage 1 is the earliest, and that's usually where it's localized. And stage 4 is the last stage, and that's typically when it's gone to other parts of the body.
Okay. You know, does the staging change your lifespan and what treatment you may get?
Absolutely. So the earlier the stage, the better the prognosis. And the treatment differs drastically. So patients who have what we call stage 4, where it's metastasized, in most cases, we don't have the ability to cure those patients. We can certainly treat. In select cases, we can still cure them, but by and large, once it's spread to other parts of the body, which is stage 4, it's what we call palliative. So in that situation, we're not treating for cure, but we're treating to potentially extend life and to treat symptoms. Patients who have stage 1, their prognosis, or what we call their overall survival, is the best. Patients with stage 4, they have the worst survival. Mm-hmm. We tend to treat, and again, this is just a generalization, from a surgical standpoint, and it depends on the particular cancer, but stages 1, 2, and 3 are usually within the realm of what we call surgical cure, in addition to other therapies. But again, once it's gone to stage 4, it's limited in terms of what we can do surgically.
Mm-hmm. Mm-hmm. Dr. Anderson, did you have any?
Yeah, so just so we understand, you know, the whole tenet of cancer science is complex and multifactorial. We know that our bodies intrinsically has a defense mechanism that spans the gamut of everyone's thought process. So we now lean on our intrinsic immune system. And there are immune defenses that we have intrinsic that for cancer to propagate, it actually manipulates normal cellular processes. So intrinsic in all these cells are programs that control how they grow, the number of cycle per progeny, and so on and so forth. One phenomenon out there is apoptosis, programmed cell death. And there is genes, for example, the p53 gene, that supposed to control how these cells live and die, their longevity, and so on and so forth. Loss of your p53 ability, these cells now grow out of control. So to echo what Dr. Clark mentioned, what is cancer? These are cells that are growing out of control. But also, you know, intrinsic in our defense mechanism is our ability to use nutrients, how we provide nutrition to our bodies. So some of these cells, once they grow out of control, they themselves secrete substances that impacts things like your appetite, affects your weight, so you lose weight, and your ability to utilize nutrients to bolster your mechanism. And, you know, we can talk about T cells and immune responsive T cells and how they impact on cancer. And now those phenomena are being manipulated to treat cancer themselves. Also, you know, these cancer cells secrete substances like cytokines through, you know, what we call an autocrine, which is the substance that each cell communicate with each other by secreting substances that cause these cells to now automate their division. They go by a paracrine, where they stimulate distant cells that secrete other substances that encourage them or invite them in, so to speak. So the whole concept of metastasis is more than just the cells getting into the blood vessels and the lymphatics and circulating, but there's also immune factors that influences how they metastasize, where they metastasize to. For we know, for example, there are many cancers that like to go to lung or liver or bone, but there are cancers where you rarely see metastasize like that. For example, the basal cell carcinomas, they're typical skin cancers that just grow and take over locally and destroy everything in their path, as opposed to things like some of the high-grade uterine cancers that even in the early stages will metastasize very early. So it's multifactorial, and the science is now being utilized to now create a new set of treatment paradigms, a new set of, we talk about targeted therapy. So now we're starting to figure out how we can do some genetic manipulation, how we can do some targeted therapy, how can we affect the generation of new blood vessels that provide nutrition to these cancers. So these are some of the basic ways that we see cancers going from one place to the next.
Right, right. Let's, there are some, we have so many questions. Let's keep going here. Dr. Garrison, there's a question for you, vascular. Can you explain the difference between an artery and a vein, and why sometimes we get clots in our lower extremities, be it either a vein or artery?
Okay. Well, the system is designed from the heart. The arteries deliver blood with oxygen to the tissues and the organs. That oxygen is used for fuel to propagate the metabolic that we have. The veins bring the blood back through the lungs and then to the heart. There are differences in the arteries. The arterial system is a high pressure system, so there are layers of muscles within the arteries, whereas the venous system is a very, very low pressure system. So the veins themselves have very little muscle in them and are very, very thin in origin. Now, specifically, when we talk about circulation, we're describing the delivery of oxygen to tissues. And I think Dr. Atherley earlier talked about how a heart attack occurs, that you're not getting enough delivery of oxygen to the tissues, either through blockages or narrowing of the arteries. That occurs in the legs and the arms as well, and also in the brain. But more specifically, the question was asking about clots. Well, the clots form in the veins, and they form because either the blood is too thick, the blood is moving too slow, or there's been injury to the tissues. That is called Virchow's triad. And when those factors occur, you can get clots. And we're specifically talking about the clots in the lower extremities or the legs. If those clots are in a certain position or a certain vein in your leg, they can break off and they can go through the blood system to the heart. And you can get a condition called pulmonary embolus, which could be fatal because it blocks the blood from receiving the oxygen that it needs to be pumped out by the heart. So how do we prevent those things from occurring? One is we have to make sure that we're hydrated and we drink lots of water. Two, exercise and mobility. We must constantly stay moving. And three, we must protect ourselves and make sure that we don't have any serious injuries to our lower extremities. Those are some simple factors. For instance, when you're flying on the plane, a recommendation is to drink a glass of water for every hour that you're on the plane, and also to get up and walk for every hour on your plane to prevent the blood from standing still or getting thickened, which can cause those clots, which go to the heart and lungs and could be potentially fatal.
Excellent, excellent. Anybody else want to chime in on this?
Omar, can I just ask to say something real quick? I can see a lot of questions coming up, and I realize we're not going to get through all of them. So
Yeah.
I'm typing some answers in real time, if that's okay.
That is fine, Patrick. That's fine. Yeah, definitely, man, because a lot of questions are coming in. They really are. These are some questions. I'm sorry, someone was going to say something.
That's me. Let me finish up on this. There was a question about a Greenfield filter in there.
Right, there was. Yes, you want to. Yeah, that's definite because actually, yeah, there was a question. Go for it because that was sent.
Well, a Greenfield filter is a device that's placed in the major vein of the body called the vena cava. That filter is placed, and it looks like a little metal spike. And that filter is placed when people, one, cannot receive anticoagulation for various reasons, or they have failed anticoagulation. And so place this filter. Even though the filter is there, there still is an incidence of pulmonary embolism that happens, and it's about 3%. Before, we used to place those filters prophylactically, and this question specifically asks how long can one have a filter?
Filter, right.
Data is showing that there are consequences of having placed these filters, but they are necessary for short periods of time. So what we're doing now is placing removable or retrievable filters, and we leave those in for a short period of time, maybe 6 months, until the therapy that the patient is receiving or they're out of that risk zone to develop pulmonary embolism.
Right, right. There was another question that came in, and what it stated was, will someone discuss vaping in the youth? Anybody have any experience with young people vaping and side effects or non-side effects, or what we can do about it, whether that's going to help them get off of cigarettes or they're going to make them smoke more, or will they be lung cripples when they turn 65? Anybody have any suggestions on this one?
Well, you're the pulmonologist. Why don't you?
Yeah, I know. That's why I asked the question, because I don't have any answers. It's something new, and it's supposed to be, relatively safe from what we understand, because it's a mist as far as real smoke. So I think we have yet to find out as far as what the ill effects are from vaping, but time and it will show its ugly head. So all I can say is that we're going to give this time, and we'll know.
I think it actually has shown its ugly head. There's a whole lot of conundrums with it, in the sense that when it first came out, a lot of these kids would, stop smoking, and it's safer and all that. But then, if you notice, and then of course there was a whole lot of money put into advertising it, again, like they did way back when cigarettes first came, targeting the young ones to get them to smoke. Now they're doing the same thing with the vaping. Now, if you look on right now on your TV screen, you will not see them advertising it like they used to a year or 2 years ago, because they're cracking down on it. I think the American Academy of Pediatrics came out and said, look, this does not reduce, it actually increase the risk of addiction
to cigarettes, or
other issues as well.
Right.
And taking that into consideration, like you said, it's mist and all that. Now, caring for that instrument that they use to smoke, is missed. Viruses, infections, bacteria get stuck on those things. How well are they kept and all that, and increase the risk of infection, especially lung infection as well. So that's the reason why they begin to crack down on it, and you don't see it advertised as it is.
Right, right. Yeah, you're
Omar,
right.
I'd like to just chime in too.
Go ahead, Dr. Sproul.
Yeah, as Nelson said, the American Academy of Pediatrics has come down hard on it. And people need to understand that there was a lot of emphasis on younger kids, because one of the things that these companies are looking at is to create addiction to nicotine. So a number of the things that are being vaped are contain nicotine, and nicotine is still addictive. Mm-hmm. The other thing is that there have been a lot of respiratory complications associated with vaping. And part of what's unknown is, and again, with the increase in the availability of marijuana, THC, a lot of the vaping that's being done is being done not just for for the nicotine, but to get high. And so you then have the issue of whether or not what's being vaped is something that is reputable, or whether or not it's tainted, or whether or not it's contaminated. And whenever you throw in those kinds of issues, there are all sorts of untoward reactions that can occur. And so, number one, the company that everyone kind of knows about, the Juuls, the electronic stuff that came out, has all sorts of flavor types of things and things like that. But I think the more dangerous stuff is when people are buying things to be vaped that are not under controlled circumstances. So I think it's potentially very dangerous, especially the way that tobacco was geared was to get folks addicted to the nicotine that was in it. Now they removed the tobacco, but now they're getting you addicted strictly on nicotine. So you need to be completely transparent about what it is you're vaping and what the people that are making money on it are trying to do.
Right. I understand. Yeah, that's so current right now, and I think we just have to understand that the kids and the young people, this is something that's geared towards them. I think that it's going to be a big problem, and if we don't get on it, it's going to be a worse problem. Let me take another question, Doctor. I think a lot of people can chime in on this from different specialties. Dr. Atherley, we have a lot about cardiology. Specifically, my blood pressure meds over time has caused my heart chamber to beat out of sync because of fluid slowly building up on my lungs over time, causing shortness of breath. Recently, over a week or so, the shortness of breath has become very severe. I had to be rushed to the emergency room. The doctor there, with the use of diuretics, were able to expel over 24 pounds of fluid from my body and brought my breathing back to normal. It sounds like, this is a congestive heart failure. Can you tell us a little bit about what's happening to this person and how we can move forward? Because with hypertension and diabetes and congestive heart failure, it all plays in the same realm, and those are targets for African Americans. Let's talk about this.
Yes, it does sound as though the questioner does have or did have congestive heart failure. Now, what exactly is that? It is failure of the heart to function effectively as a pump. Now, many things can affect the heart muscle function, and hypertension or high blood pressure is one of those. When the heart has to pump against a higher pressure and increased resistance of the arteries, peripheral resistance we call it, then it is overworked. It may become overworked and may manifest this effect by thickening the heart muscle. The heart muscle becomes gradually thicker and thicker. This is of the left-sided chamber especially, the one we call the left ventricle. And this may become thicker and thicker in an effort to pump harder, pump more strongly, to push the blood out against this high resistance, high blood pressure. Not only may the heart muscle become thickened, but it may also become dilated. The chamber may get bigger and bigger, larger volume of blood being retained in it. And when the heart no longer pumps effectively, then it may allow backup of fluid on the lungs. So one of the manifestations of failure of the heart is congestion of the lungs or increase amount of fluid in the pulmonary vasculature, the pulmonary blood vessels in the lungs. And this is probably what happened to this patient. that the heart was failing, not pumping blood forward effectively, and allowing a backup of blood and hence fluid into the lungs. This could cause shortness of breath, and one of the obvious treatments for this would be to try to have the patient pass more urine out. The best way to get rid of the fluid in the lungs is by having fluid excreted from the body in the urine. So a diuretic or a water medication would be one of the first choices. However, when the heart has truly failed, one may require more than that. There are medications we can give you to help increase the strength of the heart muscle and have, by a variety of different mechanisms, improve the overall function of the heart muscle. So in hospital, this patient may have been given a diuretic or water medication, but there are a variety of different classes of medication that we can use to treat the so-called congestive heart failure. We may want to expand at some point on the effects of hypertension or high blood pressure, but certainly that is one that we're most concerned about, the potential for congestive heart failure as a consequence of overworking the heart from hypertension.
All righty. All right, thank you. There was another question about third-degree heart block. Would you believe that? But we already covered that. We're not going back there again.
Okay.
Actually, there's a question for me. This is the first time I've had a question. It says, Dr. Bay, how is COVID-19 affecting people with lung nodules and other pre-existing lung conditions since it is an airborne disease? Thank you. I won't mention her name, but it's thank you, B. Basically, what we realize is that in patients that come in that are asymptomatic and are tested positive for COVID, there's really no symptoms, there's no lasting effects, there's no permanent lung disease with these patients. Now, what we find, and because we see this in the ICU under critical care, is that patients come in because this is truly a virus, and viruses can cause pneumonia. And pneumonia, definitely, obviously, it's a primary infection, either a virus or bacteria or a fungal, some organism in the lung tissue itself. Not just the airways, but it's in the tissues itself. So that infection inhibits oxygen from coming from the lungs into the bloodstream because the lung tissues aren't working appropriately. This is pneumonia. Now, a lot of COVID patients that come into the ICU that are critical, most of them will have pneumonia. And the pneumonia is diffuse, meaning that it's in all lobes of the pneumonia. All lobes of the lung. Basically, our lung is a very delicate tissue. Anytime there's an infection or an insult to the lung tissue, when it heals with a scar. And our lungs function as just like a balloon. If you take a deep breath, it stretches out, and when you exhale, it recoils just like a balloon. Well, scars do not stretch. So when after something like a severe pneumonia or a severe insult to the lung, or an insult that happens over a long period of time, like smoking and the chemicals that are in the smoke that damage the lung tissue, it won't allow the lungs to stretch because scars don't stretch. So once that pneumonia clears, there's a lasting scar left behind after the lung heals that prevents oxygen going across the membrane from the lung into the bloodstream, number one. So you may have decreased oxygen or the ability to get oxygen into your blood. And also it decreases the amount of air that you can take in when you take a deep breath so that you're short of breath. So yes, it can have lasting effects if you have that type of those type of symptoms where you develop pneumonia from the COVID virus. Now, will over time with appropriate physical therapy or lung therapy and utilizing your lung and moving along, will you regain some of that? The amount that you regain all depends on, number one, what your lung functions were prior to the infection, and number two, basically just how healthy your body is and how you rehab yourself going forward. there's a good chance that you will lose lung function, though, if you have pneumonia from COVID. Hopefully, I answered your question. All right. Anybody else want to chime in on that?
Yeah, Omar, I'm going to throw it to you. There was an earlier question about an individual that had asthma that thought that they had outgrown it, and it came back. And I think that, you know, a lot of people believe that they outgrow asthma, and in many cases they don't. It's just that the symptoms get better as they get older because their airways get larger. But a number of individuals, if you do some simple pulmonary tests, show that they have some issues of reactive airway disease.
Right.
And those individuals might be of greater risk if they have COVID infection as well. So the issue about outgrowing asthma.
Yeah, well, the thing of it is that asthma is a bimodal disease, all righty? Usually, when you're early in life, asthma, as you said, your airways are more narrow, mucus, you just love to produce mucus as a kid, and those airways get clogged up, and there's a lot of bronchospasm, a lot of spasm in the airways. So the kids really have a lot of exacerbations. They have the potential to have a lot of...
Explain bronchospasm a little bit, that people may not know what that is.
All right, bronchospasm, what I'm talking about is that the airways actually go into spasm. Like if you have an airway this wide, and then for some reason, it can be inherent. There doesn't have to be a stimulus to cause it, or it could be something like an allergy or a pet dander or something like that comes in contact with the tissues of the airways, and the airway just closes down on you. That's spasm. It just closes down, and you have a hard time getting air out, actually a hard time exhaling as opposed to inhaling. But the thing of it is, what I was saying, it's a bimodal disease, meaning that it affects you when you're young, but sometimes about teenager or early 20s, it seems to go away, or it gets much better. It doesn't affect you as it used to. But what happens is, as we live and things are affecting our airways and our lungs, that asthma, when we may be 35, 40, or 50, it starts seeming to come back. And that's just that's why we call it a bimodal disease. It affects you when you're young, and it comes back on you when you're older. Okay.
And a follow-up, someone wrote a question about the smoke that's out there in the West affecting the lungs.
Oh my goodness, that's real. That's real. What you inhale, especially if you have a lung that's susceptible to it. If you have, number one, if you're a smoker and you have COPD, or if you have bronchitis, or if you have emphysema, that will affect you greatly. Any insult to the lung, and you're talking about irritants in the air. You're talking about different chemicals in the air that will affect your lung tissues as well as your airways. Yes, you will be affected, and to some degree, it depends on how much exposure you come in contact with. It can be permanent damage, definitely. All righty. Let's go on. There was a question.
Omar, there's a couple questions people had about cancer screening and prevention.
Right. You want to tackle some of that right now?
I can finish it off.
All right. I haven't gotten to
I'm
I have so
answering.
many questions in front of me that if you see one that you like, Kevin, do you know where that question is?
Well, it started off as how do you prevent and identify prostate cancer? But I'm sure it's the same question applying to colon cancer, breast cancer, and other cancers.
So actually, I was in the middle of writing an answer for that one, Kevin.
Kevin, go ahead, Pat.
No.
Well,
let's talk about it. Go ahead, because others may want to chime in.
All right, let me talk about this, because I believe I know who wrote this question, which is interesting. The question is, what's the best way to prevent and identify prostate cancer prior to a prostate exam? And it's a loaded question, but what I will say, and Kevin began to address this, is this should, since this is community service and education, we should think of it in terms of educating with respect to how we address cancer and identifying cancer early. Typically, there are two major factors that we need to consider when it comes to cancer, in that we need to understand that all cancers are genetic disease. And with respect to genetic disease, they're the genetics that is acquired through spontaneous mutation, which means it occurs throughout lifetime, whether it's related to environmental or lifestyle issues, infections, chemicals and those kind of things, electromagnetic rays, or through genetics, which is passed down through generation. Now, with respect to the acquired group, the goal there is to be aware of your surroundings, be knowledgeable as to what some of these carcinogens might be, and then understand that there is a set of recommendations, whether by the NCI or the WHO or our various medical specialty organizations, when to screen for what disease and when to start. So for example, in general, colon cancer, in average risk patients, you start at 50. For breast cancer, you start around 40. But when it comes to prostate specifically, we always say for African-American men, we start around 40. Now, what does that mean? In general, we talk about getting PSAs done and prostate exam. Now, it's interesting that the question was asking prior to a prostate exam. And I think there is some aversion to having prostate exams, as we all know as men how this occurs. But that should not get in the way of getting a prostate exam, because cancer screening is not the only reason to have a prostate exam. If you wake up and there's blood in the urine, if you wake up and you have pelvic pain in a man, if you wake up and you have trouble urinating, you should have a prostate exam. That's totally unrelated to even thinking about cancer. But since we're on the cancer issue, there are several things that we think about, and it ranges from smoking to alcohol use to caffeine intake, on and on. If you believe it, it could cause it. If you don't believe it, it may not. But the long and short of it is, as men of color, we start very early, because the goal there is, one, try to eliminate the environmental factors, but two, identifying the disease early where you can intervene at an early stage. As Dr. Clark mentioned before, the earlier you find it, the better your prognosis. Even though there are intrinsic factors in everybody's tumor, as in the tumor genetics itself, not necessarily your own somatic genetics, that does influence how the disease behaves. So for example, an early stage disease in one individual may be even more virulent than a late stage disease in another individual. And then there is the inherited genetic aspects. In that setting, you may not be able to prevent getting the cancer, your genes are what they are, but again, knowing your history allows you to engage in what I call risk assessment. And once you've identified your risk assessment and know where you fit in that spectrum, then the question becomes, how early do you start screening so that we can identify disease at an early stage? And for now, the more common modalities that we have for prostate is, the PSA, or the prostate specific antigen. I know there's some controversy as to how effective and what it means. And then there's the prostate exam. Now, there are men who will develop prostate cancer and have a normal prostate exam. And that's why, especially if you're in a risk group, then there should be some multi-modality approach to screening, whether that includes digital rectal exam, PSA, and ultrasound. And it's at that point where you start to think about, if I have an inherited genetic defect, then how can I prevent getting cancer? And that's when you start to think about, in general, prophylactic intervention, whether it's surgical, hormonal medication, to try and mitigate the risk of developing the disease.
Right. All right.
Patrick, just one other thing related to that. There's been some evidence to suggest that sexually transmitted infections like chlamydia and GC very often have an associated prostatitis. And some people believe that if you've had multiple infections with either chlamydia or gonorrhea, that might be something that increases the chances of your having prostate cancer and might want you to have prostate examinations done earlier and maybe possible testing for cancer.
Mm-hmm.
Yeah, I mean, I think what that implies, in a similar concept, if you have any sort of chronic inflammatory process, which an infection can be one of those things, that can also contribute to cancer.
Mm-hmm.
It's
Okay.
important. So the controversies with prostate cancer testing, I think it's beyond what we should discuss here. Same thing with breast cancer screening and mammography. But I think it's important to understand, as Dr. Anderson mentioned, your risk. And I think there's certain things that put you at high risk for prostate cancer, being a Black male. So, in being in a high risk group, what your particular screening recommendations should be, and specifically sticking to that screening recommendation. Because again, the best thing, we cannot prevent all cancers, because cancer actually is natural. It happens from just having mutations or certain things that can augment that process, but you can't completely prevent the development of cancer. So having said that, the next best thing is to catch it early. So if we catch stage 1, our ability to cure that patient is much better than if we catch it at stage 3.
Right, right. There's a question, we're going to move on. There's a question for Dr. Lee. All righty. I have a bad hip and they say I need surgery. I'm scared to go under the knife. Please advise.
That's a tough one. I think many of us are scared to go under the knife. I think part of the issue is knowing what the diagnosis is. And, when we have a surgical discussion with the patient, we always talk about the risks and the benefits of surgery. And when I've known them for say 4 or 5 years, and I know they have arthritis of the hip, if I notice that suddenly that, they come in limping, or, they come in a wheelchair and say, hey, my hip is that bad, I can't walk anymore. Maybe an aggressive conversation where, I notice that you can't walk, and, if they become wheelchair bound or bed bound, there's other consequences, such as stuff we talked about, blood clot, urinary tract infections, ulcers, and general illness. And it really depends on, how much pain you're in, what kind of treatment you have, and there are certainly non-surgical treatments that are available. So it's perfectly natural to be scared to go under the knife, but I think it warrants a true discussion with your surgeon. What are the risks of this surgery? What are the benefits? Are you at a point in life where this hip is so bad that if you don't get it done, you're going to head backwards and not be mobile, and suddenly maybe you're not able to drive, or you need to be on crutches. If you're able to avoid that and to have improve mobility and quality of life through a surgery, then it may be worth it. If it's not, if the pain is just okay, and 2 Tylenol, and it flares up every 6 months, and I would probably tell you, wait, it's time. So surgery it's a big thing. It's a big procedure, and anxiety is associated with that. But I really think it warrants a in-depth discussion and what you stand to gain from it or lose.
Okay, let me just thank you very much. Let me just take this time to and we ran over a little bit. I was supposed to do it at halftime, but reintroduce everybody. Goodness, well, what I'm going to do is let me do it, and we can do it faster because we have so many questions and we're running out of time. Two hours is short. Dr. Atherley is a cardiologist, interventional cardiologist. Probably the smartest person I know, just to give him a plug up. Just to understand, I trust everybody look at the names to see who I'm talking about. Dr. James Lee Jr., he's an orthopedist, and the second generation orthopedist, and we really appreciate him. Dr. Nelson Aluya, he is internal medicine as well as pediatrics. And we really appreciate him and all he's doing at Bethesda Medical Center. And definitely for Nigeria and the UN. Go, Dr. Aluya. Dr. Douglas is our infectious disease doctor, and he's been on the front as far as COVID is concerned with all the patients and helping out. Dr. Kendall Sprott is CEO of Matheny Health, and he is a pediatrician with a critical care background, as well as Dr. Court in internal medicine. And he's just probably got the biggest practice I know, and hopefully I know that a lot of his patients are looking. Dr. Kevin Clark is a surgical oncologist, and appreciate having him here, as well as Dr. Patrick Anderson, who is a GYN surgical oncologist. Boy, the big titles, guys. And Dr. Jordan Garrison, bariatric surgeon, vascular surgeon. For many years, I remember back in the day when at UMDMJ, he was the trauma surgeon. So he has a lot of experience in many aspects of medicine. And I'm Dr. Omar Bey, pulmonary critical care and nutrition. Okay, one thing I would like to say is that we're going to be here every second Saturday at 1 o'clock. All you have to do is go to OBHealthy, scroll down the page at the bottom, and just hit the Zoom positions, and you can come on and come on to the webinar and ask your medical questions. All right, that's every second Saturday at 1 o'clock Eastern time. All right. Also, I need to state is do not change any aspect of your medical care until you consult your physician. That's so important, okay? And also, I would like to thank OBHealthy for allowing us to use their platform. They're a weight loss product, and boy, they do so much for the African-American community. So, Dr. Court, this is a question that came in under blood pressure. My blood pressure is usually 170/80 for the top number and about 90 to 105 for the bottom number. My doctor can't seem to get it under control. Why aren't the blood pressure medications working for me?
I certainly would like to know more about the patient. Is this an obese patient? Is the patient compliant? Has the doctor tried different classes of medications to control your blood pressure? Those are very important things. What type of food does he eat? Is he compliant with a low salt diet and exercise? Does he take his medicine on time? Or is he, he skips a day or two? Or does he manipulate his medicine on his own? Or does he follow his doctor's directions? I would certainly need to know what class of medicines were tried in the past for the patient. There are different classes. They work differently for different people.
Right.
And that's most important.
Right. And they work differently for different cultures too, right? I mean, for African American as opposed to Caucasians.
That's correct. African Americans tend to respond to diuretics and calcium channel blockers, as opposed to Caucasians who respond better to beta blockers and other classes of medications.
Do you think that's because
we need to know what was tried?
I'm sorry, Dr. Court, say that again.
We need to know what the patient was tried on, how compliant the patient is. Those are the key factors. With diet and taking their medicine like they're supposed to.
Right. Now, Dr. Aluya, you have a closer and direct connection with Africa than I, even though I'm descended from there. But do you think that because we come from a warm climate and over the generations is one of the reasons that we respond to water pills a little better?
Well,
I know. I just threw that one in there for you.
I know. Looking back, and I must say this, and I also say this in a little bit of a jest. When God created us, He kept us way back in Africa, and that's the reason why we're the color we have and the melanin that we have. So I guess the intention was not for us to be up in the temperate region. But back in Africa, the sun is high up, the heat intensity is high, so we tend to lose a lot of fluids as we went out to the farms to work. So we needed to retain salt so that we can keep our volume and don't get water in us and don't get dehydrated. So, but as time moved on, and we moved up here, the sun is not as intense. We are not losing as much water as we should. So we don't need to retain that amount of salt. So invariably, that's the common, the analogy that, hydrochlorothiazides, the water, the diuretics, or those ones that help you lose salt, tend to do better in us than other kind of medications. However, that's when we didn't have what we have, diabetes now. And I must say, diabetes is beginning to affect us as as a people far more than any other race on earth. And I'll tell you why. We must remember that life actually began in Africa. So, those who started the migration of leaving Africa, if you look at the planet, as you leave Central Africa where life was said to have begun, as you move on, the skin is lighter, the hair is lighter, is less, coily and stretching out, all to where we are now, where we have, straight hair and very light hair and blue eyes without genetic moderations or alterations for people to adapt to this environment. So, but, here in the 80s, only the 80s, it was actually described in textbook that Africa is a continent without diabetes. But right now, because of lifestyle changes and all the things that are affecting us, and then those of us who of African descent who live here, because we haven't genetically altered our DNA to adapt to this environment. We only came here 500 years ago compared to people who came here over 30,000 years ago. So diabetes is affecting us far more than usual, just like the COVID is affecting us far more than usual here. So environmental factors, vitamin D, diet, sedentary lifestyle and all that, these are issues that are taking place. Now, coming to high blood pressure. So what I often tell people now is, look, for you to take your blood pressure pill, please review if you also have diabetes and review if you're leaking protein in your urine, because we know that there are medications that actually protect your kidneys with the effect of high blood pressure and diabetes. Because if you look, the number one cause of kidney failure in the world is diabetes. The second cause of kidney failure of the world is high blood pressure. So if you have both, it's a double whammy. And of course, the third, most people don't know, is polycystic kidney disease. And you'll be shocked. It's out there. Was begin to say a lot of it. So as you take the medication, decide the medications to take to treat your blood pressure, see also the ones who protect your kidneys and protect your heart. Because, as Dr. Attali will, confirm, this medication also protects the remodeling, the shaping of the heart from getting too big. So these are medications that you need to discuss with your doctor.
All righty.
Just two quick comments on the hypertension.
Go ahead.
One is the concept of the prevalence of hypertension in African Americans here compared to Caribbean and in Africa. One of the theories that existed was of genetic selection, where those who could hold on to the salt better when we travel across the involuntary journey that we made in the holds of the ships, that those who were able to retain their salt rather than sweat it all out had a tendency to survive better here. And so that may be the forebearers of those of us who now suffer here with that salt retention as a problem. The salt retention then contributes significantly to the hypertension. The other comment I'd like to make quickly is that depending upon our treatment of hypertension depends on several factors. It is apparent that patients who have very significant hypertension cannot get away with just one tablet. In addition to taking proper preventative measures with diet, etc., we will find that most patients who have severe hypertension, severe high blood pressure, will need 2 or 3 different medications, preferably of 2 or 3 different classes. So we will have to, even though we may select one as being predominantly more helpful in African Americans, essentially and eventually we may find that we have to use several different medications of a variety of classes.
Right. Okay, definitely.
Sorry, if I may add something to that. As a pediatrician, often enough we tend to forget that kids also have high blood pressure, and it's imperative that as parents and pediatricians and guidance of young children, we begin to take a look at that as well. As the obesity in these kids increase, the risk of high blood pressure also increases. I mean, they've had a lot of studies that have been done to monitor what is called hypertension in children. They recently revived that, but new studies are beginning to show that long-standing high blood pressure, even in children, over a course of time, actually damage the vessels uh, right from the heart and even the heart itself. So it becomes harder to manage, high blood pressure as you grow older with high blood pressure as a child.
Okay. I have a question about community-acquired pneumonia. Dr. Taylor, can you help us out as far as that's concerned? Is the vaccine effective? Should they take the vaccine, and who should take the vaccine?
Community-acquired pneumonia is not caused by only one bacteria, but the commonest, of course, is pneumococcus, which we have effective vaccine for. The guidelines are that anyone with any underlying chronic lung disease or heart disease should have it. And they should have it every 10 years. People with immunocompromised illnesses like HIV should have it every 5 years. Of course, this will prevent pneumonia due to pneumococcus, but not to other pneumonias. However, since pneumococcus is the commonest cause of pneumonia, it will cut down the rate of pneumonia significantly. Yeah, I know I have a hard time convincing patients to take the pneumonia vaccine, but it's something that everybody will have to talk to their patients about.
Okay. All right. Thank you. Anybody else want to chime in on that, or we're going to go ahead?
Those with underlying lung diseases, especially, and people who are 65 years and above.
All right. All righty.
There was a question. There was a question about somebody talking about the shingles vaccine, that he had the first one and has mixed. He didn't get the schedules, the next schedule, which was supposed to be given within 6 months. My advice to him or her is to go ahead and have it. It doesn't matter. To go and have it.
All right. All right.
So just maybe someone could help explain what the definition of community-acquired pneumonia is versus other types of pneumonia.
Yeah.
Walking pneumonia. Isn't that what we call walking pneumonia?
Well, I think
community pneumonia is somebody who has not had any exposure to the healthcare environment. But again, it's very difficult to define. I mean,
yeah, because I think
for example, if a doctor gets a pneumonia, I will go to the hospital every day. Are you going to classify us as community-acquired or healthcare associated?
Yeah. Go ahead, Dr. Sproul.
The definition, if you think about community-acquired, it means that you're acquiring it from the community, as opposed to getting it in a nursing home or getting it in a hospital. And for the most part, my common sense says that a large number of community-acquired pneumonias are viral pneumonias, not necessarily bacterial pneumonias. And I think that when you talk about bacterial pneumonias, a lot of the bacterial pneumonias that people get are complications of viral upper respiratory tract infections. And it's infections with the bacteria that are living in the nose and throat, not causing any problem, but then are allowed to get into the lungs because you lose some of the protective mechanisms that keep stuff from getting down low. And so some people think of it as strep pneumo, and I think that's part of the question as it relates to the pneumococcal vaccine.
Pneumococcal.
And the problems associated with pneumococcal pneumonia, which are fairly common. But for the most part, that strep pneumonia is in your nose and throat already. And it's not as if you've sort of gotten that from someone else. You could, but it's unlikely. So I think that when people talk about community-acquired pneumonias, logically, that means that a lot of it is viral, and you kind of can't prevent that except via some of the mechanisms that we're talking about. But bacterial pneumonias, for the most part, I think are really pneumonias that occur because of germs that are in your nose and throat that are allowed to get in when you have upper respiratory tract infection.
Right. And pneumococcal pneumonia is the most common cause of pneumonia that we find. And that's why they developed the vaccine for it. And Dr. Taylor is right. Anyone who has any like HIV or a serious lung disease or any diabetes, whatever, you should get the pneumococcal vaccine, definitely. Because anytime you have just like COVID, Those patients that had diabetes or had hypertension or had heart disease or COPD or especially obesity, they were targeted from COVID. So I feel that other viruses are the same way, and bacteria is the same way. If you get a severe illness, the likelihood that you're going to have a stormy course or a worse course or a more difficult course is real if you have some of these secondary or other diseases, and that's for sure. So flu vaccine, pneumococcal vaccine, yes.
That vaccine, before it came out, was first developed for children, and pneumococcus was one of the major causes of ear infections as well as pneumonia. And so it's been a big boon in terms of protecting kids from both ear infections and pneumonia, as well as older adults who tend to have issues with it as well.
All right. There's a question that came through. It said COVID is prothrombotic. Yeah. All right. What does that mean, right? Okay. So basically, let me just go back with COVID and ICU and critical care. There are many things, and I'll preface this is that we still don't know a lot about COVID. So, but we notice in those patients that have severe illness with COVID, there are several things that occur, and most of the patients get this, and these are the patients that were, unfortunately expired from or died from COVID. Number one, they would have the severe pneumonia. Number two, they would have a kidney failure, and they would have to go on dialysis. Within 1 or 2 days, their kidneys would fail them. Number three, we found that there were what they say thrombotic. What they mean by that is that their clots form in the blood vessels. So some of the patients actually had strokes, or they found things like what we call pulmonary embolus, or blood vessels, clots in the blood vessel in the lungs. There were so many things that were happening with the patients with COVID, and still, even today, we find those patients that are coming. Fortunately, in New Jersey, we don't have the numbers that we used to have, but still we have the patients coming in that are very, very sick with COVID, and they are having these comorbidities, or this is the sort of the other problems of COVID that we're finding, and we're finding out more and more each day about how this virus is affecting our body.
Just one comment about this in pediatrics. They say that children tend to not have the kinds of deaths related to it that adults do, but we've seen something called Kawasaki's disease,
right?
Which and when Jordan's no longer with us, but he talked about issues of clotting occurring when there's low flow, as well as if there's damage to the vessels. And it appears in pediatrics, at least, that there's damage to the medium-sized blood vessels. And whenever you have damage to blood vessels, you will have clotting. The platelets that are circulating in the bloods that help the blood clot tend to stick around there. And so there have been significant issues in those individuals who've had Kawasaki disease that's having those kind of thrombotic or those clotting issues that affect various parts of the body, and they can occur all over. So it can be a serious complication, but we believe it's related to somehow the damage that occurs with exposure to COVID to the medium-sized blood vessels in kids.
Yeah, yeah. You know what I would like to do? Dr. Aluya had touched on diabetes a little bit, and he was talking about diabetes, but I just want somebody to explain what is diabetes. I mean, it's affecting our community. I truly think that if we as a community, African-American community, could get diabetes under control, there would be so many diseases that would just decrease. The renal disease, your vision wouldn't get bad. Your heart, I mean, it just affects so many aspects of our lung. What is diabetes, guys?
Well, diabetes is basically, I'll call it a non-communicable disease, meaning it's not due to infection, where your body cannot handle the sugar, what you eat, and the sugar your body produces by itself. So, and it comes in two ways. Either the insulin has failed. Insulin is the one that actually allows the sugar or the glucose when you eat, as broken down into your body, to get into the tissues. Now, insulin is the product or the item, I'll use the term, that allows sugar to sugar into your cells. Now, the only other part of the body that don't need insulin for it to take its own amount of glucose is the brain. So every other part needs insulin, and even the muscles as well. And that's why when they talk about muscles and insulin exercise, it's really good that you move, because when you move, insulin works better. Now that's one. Insulin fails. Now the other one is if the insulin has a resistance, meaning there's something blocking it from getting into working, by some mechanism, so that your body begins to respond to it, and it can allow the sugar or the glucose get into your tissue. And then, based on what I just described, when the insulin fails or the body is not producing it, it's the type 1. And when there's an increased resistance, it's the type 2. Now, we have what they call the type 1.5, which is the latent autoimmune diabetes of the adult, which is the new entity that's, within the last, first described 15 years ago, that's we're talking about now. So that actually it starts in younger individuals, and you don't necessarily have to be obese or anything like that, but it actually starts like a type 2 diabetes. So there's increased resistance to the insulin, and over time, the pancreas that secretes the insulin fails. So it starts with like a type 1, where your medication, the types will work for you, and over time, the pancreas fails, and you may need insulin injections at itself. So that is usually autoimmune disease. And of course, you have another type, which is, happens when, people are pregnant. Now, the big issue now is, knowing what your diabetes status is. And I always tell all my patients, friends, and everybody who can hear me, please, every individual, just like you know what your blood pressure is, you have to know what your diabetes status is. Meaning, are you, you're not diabetic, or you're pre-diabetic, meaning, or you're diabetic. So either one of these three categories, you have to fall, and you have to know where your status is. Mm-hmm. Now, for those without diabetes, we have what they call the A1C, which is a measure of what your sugar has been for the last 3 months. And that's just a measure to identify where you are in terms of that spectrum of disease, diabetes control. So 5.7 or less, meaning you have no diabetes, and then 5.7 or 5.8 to about 6.5, would tell you if you're pre-diabetic. Now in this country we have 80 or 90 million people who are pre-diabetic, and they don't even know they're pre-diabetic. And in the next 4 years, over 40% of them will become diabetic, meaning 65%, 66.5% of A1C and above, with or without symptoms. So everybody has to know that. Now, like you said, it affects every tissue, in your body, meaning starts from the eyes. If you start all of a sudden, you have visual problems, you can't see properly, you used to read, you can't read anymore, you need to go check with your doctor. Of course, check with your primary doctor. They'll screen for sugar first. It can cause strokes, it can cause heart attacks, and again, like I said before, earlier on, number 1 cause of kidney failure, amputations, injuries that cannot heal, and then in men, one of the early signs of erectile dysfunction. So if you're a gentleman, there's something wrong with the powerhouse, it's about time you begin to go see your doctor and find out, what's going on. The early signs, again, that people tend to find out, if you have pins and needles, you're walking, you feel, or you feel like your legs are burning, what's called neuropathy, those are early signs as well. So you have to go. Or the very important one, if you're waking up 3 or 4 times or more at night to pee, that's again early signs of diabetes. So you have to.
All right.
Nelson, if I might ask you, folks like tangible things they can hold on to, and they latch on to that number, the value of the hemoglobin A1C.
Right.
And there's a question: what can I do to reduce my hemoglobin A1C? Can you expand on answer that?
Yeah. Well, first of all, you need to know what your status is. If you're a diabetic, or you're diabetic. If you're A1C, ideally the A1C, if we by the time we consider you controlled, because over the years they've done studies to show that people who have A1C 7 or less tend to have reduced debilitating or bad outcomes of diabetes, 7 or less. We begin to show that 7 is the number that was put out there, but things are changing. Again, diabetes is a disease that's writing its own textbook, and we're learning more and more as we go on. But for you to reduce it, one, you have to have a plan, meaning, a personal plan in itself. What goals do you want to achieve? You want to attain a healthy lifestyle. And this is a conscious discussion you have to have with your doctor so that they decide the medications you take, what plan of meals you have, which you have to discuss with the nutritionist or people like Dr. Omar, who's a dietary expert. And of course, your personal plan involves one, making sure that you take your medications, two, you adhere to the diet that have been, put out for you, for your health, for your, your race, or for your, lifestyle. And then exercising, huge. We as people, we can't emphasize the need for exercising. Like I said again, the muscles eat when you move them. So and that's why people with sedentary lifestyle tend to get obese and tend to have increased risk of diabetes. So those are steps for you to have.
Yeah, I think this is such an important topic. Dr. Sprock, I remember in the past you were talking about this is a small vessel disease. Can you explain on that?
Yeah, the complications of many of the problems are related to the damage that the high levels of blood sugar cause to the small vessels, which means the eyes, which means the kidneys, which is, Dr. Luya said that the major cause of dialysis and renal transplants is type 2 diabetes, which is because of these high blood sugars. And so the issue of what was talked about is this hemoglobin A1C. And hemoglobin is sort of this structure found in red blood cells that helps to carry oxygen. And what happens if your blood sugars are high, some of that sugar sort of gets deposited on that hemoglobin, and that's how they measure it. And so Dr. Luya said that it can occur over 3 months as sort of a look back. And so the issue is, if you don't want to have an elevated hemoglobin A1C, you don't want to have high levels of blood sugar. And that means depending upon on how your blood sugar is being regulated. And as Dr. Luya said, in most cases where people have the type 2 diabetes, where they're not necessarily taking medications and they're pre-diabetic, or if they are taking medications, they really need to look at how they are eating, especially the carbohydrates that they are taking in. That means the starches and the sugars. And the most easily way that you can get your blood sugar absorbed and high is the sugars. And so there are different types of foods that and you can, again, I would advise you to talk to a nutritionist, someone who knows about it. Things that are called high glycemic versus low glycemic, in terms of how rapidly you can have a rise in your blood sugar after you ingest something. For those folks you might know of who have diabetics, one of the problems that they encounter is that they can have low blood sugar, and they tell them they either take a sugar pill or drink some orange juice. And because if they do that, then the blood sugar comes up very, very rapidly. Well, even if you don't have a low blood sugar, if you take things that are sort of high glycemic, you get a fairly rapid rise in your blood sugar. And the issue is also not what you eat, but how much of it what you eat. There's a difference than taking a teaspoon of ice cream versus taking a pint of ice cream versus a half a gallon of ice cream. You can imagine the amount of sugar that you're going to get if you take a large amount of sugar in something that's sweet that has sugar in it, versus taking something that like a sugar substitute, or say taking something like agave or something like that. And so the most important thing is that you need to look at your diet. Exercise is very, very critical, but the most important thing in terms of controlling your weight or getting your weight down is controlling your diet. And so you need to look at trying to, especially eliminating ingesting certain large quantities of carbohydrates, especially if you're going to do it at a time where you're not going to work it off. If you eat some ice cream and then you start to do some exercise, that'll keep that blood sugar from going high because you're burning that blood sugar as you're exercising. But if you eat a pint of ice cream as you go to bed at night, nothing's going to cause that to go down. It's going to stay up, and it's going to stay up for a long period of time. So it becomes important for you to talk to your doctor about if you're going to try and reduce your carbohydrates. You might want to limit the number of times you have it, and certainly the quantity of you have it, and the type of stuff that you have to eliminate some of these sugars. You know,
Right.
if you are addicted to carbonated water and sodas, which is one of the major problems we had in pediatrics, you eliminate those, that might help a lot in terms
That
of.
might help a lot. Yeah. Thank you. Well covered. There's a question: does large breasts increase the chance of getting breast cancer? Kevin, can you help us out?
Sure. So the more breast tissue you have, the more breast tissue is at risk. So certainly that is one of the factors. The other thing is you have to look at the composition of the breast. So the tissue actually that is at risk of getting breast cancer is what we call the glandular tissue. Most women with large breasts, most of it's fat. So the fatty portion is not the portion that is at risk, but really the glandular portion. So it's not just the size itself, it's actually what the composition is. And one of the things that we coined, or that term, is really the breast density. And density really refers to that composition of the glandular tissue. So that's it. It's not just the size itself, but really the composition actually is the bottom line.
So,
All right.
Kevin, might I ask you, so we also need to educate the community. Not only women who get breast cancer, but men also get breast cancer.
Yeah.
So with respect to the number of glands and the size of the breast, how does that influence the speed at which these cancers spread, at least locally, onto the chest?
So it's a little bit hard. The number itself, it's hard to quantitate, but really what it is the women who have dense breasts, and you can see on the mammogram when most of the image is white as opposed to dark, and the dark reflects the fatty tissue. One, it's hard to delineate a small cancer in that background, which is one of the issues. And two, again, the more glandular tissue that you have, the more at risk it becomes. So I'm not sure if it's necessarily an aggressiveness aspect just with looking at that. It may be that it's harder to find those cancers in that background, so they may present a little bit later on. In terms of aggressiveness, since you mentioned it, breast cancer, we spoke about stage earlier, but one of the other things that we look at is different molecular features of the cancer. So the cancers express or sometimes don't express certain receptors, and we can utilize that information to categorize the different types of cancers. So you probably heard the term triple negative breast cancer. So 3 of the receptors that we measure in breast cancer is the estrogen receptor, the progesterone receptor, and the HER2 receptor. And we utilize that information to put breast cancers into different categories. And these different categories, in addition to the stage, have different prognosis. So for instance, HER2 positive breast cancer is a bad prognosticator. Triple negative breast cancer, which means the ER, PR, and HER2 receptors are all absent, that's a bad prognosticator. And typically that's the type of cancer that young women get, and specifically young Black women. And those cancers tend to be very aggressive. They tend to spread early and metastasize early, and they tend to recur and come back after treatment. So it's not just the size. Again, it's other features that we look at that determine the aggressiveness.
Right.
I have a question.
So Patrick was talking about breast cancer in men, and I think the topic of diabetes and obesity is another issue. And I'd like, maybe Patrick or Kevin to comment about the enzyme aromatase that's related to fat and seems to have some sort of linkage to breast cancer.
Pat, you want to start?
Well, you know, we know that we use some of these aromatase inhibitors as chemo prevention for recurrence or prevention of some of these breast cancers. Some of these are medications like letrozole. And the issue there is how do they influence the effect of estrogen? So without going into details, you know, and many patients who, after they've complete their initial treatment for breast cancer, they're put on some of these aromatase inhibitors, and actually not just for breast, but in a few of the GYN cancers. And essentially, what we're trying to do is manipulate the hormones so that we diminish the estrogen effect.
And what I was alluding to, Sutter, was the relationship between obesity and increased aromatase.
Right. So I can't discuss this in detail because it's not coming. I'm not recalling. But what I do know is that in women who are obese, they do you do have increased peripheral conversion of some of the precursor steroid hormones to estrogen, and I think that's the cascade in which the enzyme aromatase influences the circulation of some of these steroid hormones.
I have a question for Kevin.
All right.
Go ahead, Dr. Court.
Kevin, I frequently get test results when I order mammograms on patients and they have dense breasts. What should be the approach of such a patient in terms of what should they do? What's the recommendation for other type of treatment and or studies that need to be done? Or how do you approach such a patient?
So a couple of things. It just means that there's a lot of glandular tissue. Now, again, the mammogram report comes with a lot of findings, and they give you a recommendation at the very end. So one of which is what the potential background or density is. And that kind of puts into context the ability to discern small abnormalities. Now, the report will tell you at the very end, and it's something called BIRADS, Breast Imaging and Reporting Database System. And it goes from 0 to 6. And it tells you at the very end what the next step is. So is it negative, benign, equivocal, or suspicious? And suspicious means that you need to get a biopsy done. Now, it's always done in the context of a history and physical examination so you could interpret the findings. By and large, in and of itself, just breast density itself, as long as it's usually done in context or in combination with a breast ultrasound. So whenever you see dense breasts on a mammogram, the reflex is to get an ultrasound so that you don't miss anything, any small lesions. As long as that's done, it's just a routine follow-up, whatever the recommendation is based on the BIRADS category. But nothing specifically itself, just for breast densities, is recommended.
Okay, excellent. You know, guys.
Another question: ultrasound versus mammography. Some people do both. Some people do. What's your thoughts about?
So if you have, it's all about being able to distinguish what's on the mammogram. So if you have good contrast, so if a woman has very fatty breast, then a tiny area will be picked up very easily. If a woman has very dense breasts, then it's very hard to pick up even a tiny cancer. So the radiologists actually, they're the ones who usually will reflexively recommend or get an ultrasound based on what the mammogram looks like. So if it's a dense breast, a difficult breast to interpret, then that's a situation where an ultrasound is helpful to rule out any small lesions. There are other things in addition to ultrasound that you could do. There's different types of imaging, so there's spot compression views and different types of views that can also help with a mammogram. So it's usually used as an adjunct to mammography, but you always start off with a mammogram. Now, ultrasound, the other thing is ultrasound is more helpful in young women because they tend to have more breasts, more dense breasts. So it's harder to delineate lesions, and it's less likely actually to have lesions in young women, although you can have breast cancer in young women. So it's more helpful to do ultrasounds in younger women than mammograms.
Alrighty, excellent.
Can I ask real quick, the role of an MRI in evaluating the breast? When would you use an MRI?
So this is kind of, I won't say too controversial, but it should be done in the context of a specific question. So if you want to utilize it just in the case of troubleshooting, so if you have a difficult breast where an imaging meaning a mammography or ultrasound, you have an area that you can't really discern if it's suspicious or not, MRI in that situation is helpful because it will give you an idea of whether or not or how concerned you should be about the abnormalities or the things that you're seeing on the mammogram. If the mammogram has multiple masses and you want to identify which ones are more or less likely to be concerning, then an MRI will light up specific areas and tell you, okay, well, this particular area is more of concern. The issue comes in with screening. So it's recommended for certain high-risk groups. So if you have a BRCA mutation, if you have LCIS, those are the groups where we utilize it for screening. But everybody else, really, it should just be the standard mammogram and ultrasound.
Mm-hmm. Excellent, excellent. Well, you know, 2 hours goes fast, and believe it or not, it's after 3 o'clock, and boy, I'm just so thankful for all of y'all, all of the physicians coming in and being a part of this webinar. In closing, and because we're going to have to close out, and you know, let us enjoy the rest of this Saturday, but hopefully everyone else out there is enjoying the Saturday as well. Don't change any aspect. Don't change any aspect of your medical care until you consult your physician. And I always say, it doesn't matter what we said here today, because this is for education. We are educating the public about their health so that they can go to their doctor and be more educated and really understand what their physician is talking about and understand why you should take your meds and why you should, you know, stay with your appointments and be on time and be there and understand what the doctors are talking about. Thank you, OBHealthy, for allowing us to use their platform, their weight loss network, and they gear themselves to African Americans as far as helping them lose weight. Understand that we will be here every second Saturday at 1 o'clock Eastern time. Tell friends, tell family, tell fraternity members, sorority members, whoever you want to tell, let them know that we are here and that we will answer any medical question. Okay, guys, so until next time, I'm going to say peace out there. You know, take care of yourself. COVID is real. Keep the masks on, keep the social distancing going, and we'll get through this. All right. Bye-bye, everyone.
Take care.
Bye.
Faith over fear.
Okay,
Take care.
All right. Bye-bye.
Okay.